I am your host, Jack Braha, and welcome to the Medcastplus show. On the show, we feature local healthcare providers and physicians to educate us on various medical conditions and provide us with some very helpful health tips. Today, we welcome Dr. David Silver, Chief of Urology and the Director of the new Prostate Center at Maimonides Medical Center here in Brooklyn. We will discuss how to detect prostate cancer and the latest treatments available to patients. Welcome to the show, Dr. Silver.
Thank you. Thanks for having me, Jack.
Good to have you. So tell us a little bit about yourself, where you're from, and how'd you end up here in Brooklyn?
You really want the whole story here.
The whole story. We've got a couple hours.
So I grew up in Colorado. I came to New York for medical school. My parents were New York expatriates, and they couldn't get away from New York City fast enough. And I stayed. I went to medical school at Albert Einstein, came to Brooklyn shortly thereafter, and did my internship and then residency in urology and in surgery at Maimonides. And I was away for 2 years as a fellow at Memorial Sloan Kettering Cancer Center in only urologic oncology. And I've been back ever since.
So tell us a little bit about that. After you did your surgical training in urology, you went on to Memorial Sloan Kettering, one of the top cancer centers available to us in the country even, and you did your training there. Tell us what is entailed in becoming a urologic oncologist.
Well, it's either a 2 or a 3 year fellowship. At the time that I was doing it, there was a year of research followed by a year of clinical. It wasn't quite the same service that it is now, and the relationship with the mentors was really very, very close. And it was an excellent experience. We send residents there now as part of our residency training program, and there's value even for a couple of months for someone who's not going into oncology to live, eat, breathe, and sleep the oncology world.
So tell us a little bit about the new center, which we mentioned at the top of the show, the Prostate Center at Maimonides Medical Center. Tell us what this means to the patients and the viewers out there today who are concerned about prostate cancer, prostate disease. What does this center do for them?
So the Prostate Center is the culmination of many, many years of work. This idea started many years ago. And there were a number of individuals who were really siloed within their different specialties. A radiation oncologist doing radiation oncology in the basement, a urologist a few blocks away doing surgery in the hospital, a medical oncologist giving chemotherapy in an infusion center. And it really coalesced around a conference where we realized that all of the stakeholders, including the pathologists, including the radiologists, should get together and discuss all the cases and interact in a multidisciplinary approach so that the patients would have the benefit of multiple opinions for their situation. So we started doing the conference probably 8 or 9 years ago, and it got a lot of buy-in. It got buy-in from the residents. It got buy-in from the fellows. It got buy-in from all the physicians, from the cancer center leadership. And then the next step, obviously, was to wrap this up as a program to formalize our offerings and ensure that every patient has the benefit of having a multidisciplinary approach, which is really the way cancer care is headed in general.
Yeah, I think the patient's feeling of the one-stop shop, meaning that under one roof, they can see all the different specialists, that there's a team approach to this. And that's very important, what you mentioned, is that teamwork approach to healthcare. So it sounds like the Prostate Center has coordinated all these specialists together. So when someone is concerned about or receives a diagnosis of prostate cancer here in Brooklyn and they want to come to the Prostate Cancer Center, what is the pathway? How are they meeting all the team members? What should they expect when they come to meet with you guys?
So there's many different points of entry into the Prostate Center. It can be through a direct referral to their medical oncologist. It could be through a direct referral from their internist, or even from someone they know who's had prostate cancer and has been treated before at the center or elsewhere. There is a point of contact. We have a prostate center coordinator, Jeff Wynn, whose job it is to field the calls and speak to patients and make a decision based on what the situation is about where they should start first. No matter where you start within the center, you end up pretty much in the same place. You end up having gotten imaging studies, having review of prior studies, prior biopsy results, of speaking with some of the physicians who are involved, and then at the end of that process is a presentation, which patients sometimes attend actually, about their case and about where we think we're as a group should be headed next. With this particular situation, whether we're ready for treatment, whether it needs more evaluation, and we try to reach a consensus, although I have to say it's not always a consensus, and that's good, To have multiple different opinions for a particular situation is quite good. It gives people options.
Yeah, I think patients don't always realize that when we find tumors, like in our practice of gastroenterology, when we find a tumor in the colon, we present it before the surgeon, the oncologist, the radiation oncologist, at something we call tumor board. And I'm assuming that's the conference type that you have there where the cases are presented. And yeah, doctors will go and argue that, hey, this might be a better treatment for the patient as opposed to one treatment. And at the end of the meeting, we come up with what the group of doctors feel is the best step forward for the patient.
But you probably don't always get the same answer.
I think every patient is individualized, and I think that's what we want to provide these days in medicine is really individualized medicine, in that some patients may be best for surgery, some patients may be best for alternatives to surgery, which leads me to the next question. What if somebody out there watching today has already received a diagnosis of prostate cancer? They saw a physician recommended whatever treatment it might be, surgery or radiation. How about second opinions? Should they still come to you for a second opinion once they've had everything done somewhere else? Can you review outside records? Can you put everything together?
Absolutely. A lot of the time, whoever sees them in the prostate center is the detective. We have to put together the case and then present it to the group. That involves getting the imaging studies together, getting the pathology together, not just the reports, but the actual glass slides with the tumor biopsy on them. Our pathologist will look at them and render a second opinion on the pathology. And then once everyone's had an opportunity to review this, we get together and discuss it. And maybe there are treatment options that perhaps the prior physician hadn't thought of. Maybe the patient is beyond standard treatment and requires a clinical trial.
Yeah, I think that's important. I tell nearly all of my cancer patients to go to a comprehensive center like you're describing, the prostate center, and always get a second opinion to be comfortable with the treatment they're moving forward. So at Maimonides, the prostate center is available to patients who have been diagnosed or suspect that they may have prostate disease. And for our viewers today, and especially the men who are watching, what are some of the signs early on that they may be suffering from a problem with their prostate, particularly with prostate cancer?
So that's the thing about prostate cancer that the viewers really need to understand. There may not be any signs at all. We do a lot of pre-diagnosis counseling for men with family histories of prostate cancer. First-degree relatives diagnosed at age less than 65 who've developed prostate cancer. There are some risk groups for people who are at higher risk of getting prostate cancer, although anyone who's a man is at risk for prostate cancer. By the time some men are 70, about half of them actually have it. By the time men are 90, almost everybody has it. But because it has a very protracted natural history, not everybody necessarily requires diagnosis or treatment. So the best screening test that we have is no longer the finger test that many of our older viewers probably had.
I am sure people are happy to hear that. The finger test is no longer the best test that we have.
I'm sorry, I know you're a gastroenterologist. I'm sorry to disappoint
Still
you.
the best test I have.
Is not necessarily the best thing to do.
People are happy to hear this.
PSA, or the prostate-specific antigen test, which is just a blood test that your internist can draw.
Anybody can order this test. Any
is
doctor
very
can order
helpful. And that's
PSA.
usually the starting point. So for patients who are at risk, family history, or Caribbean or African-American heritage, who are at very high risk for prostate cancer, a lot of those patients come without a diagnosis. Some will come with just a PSA. Say, look, my internist did this test. It's a little bit high. What should I do next? Some of them will come just for advice. My dad had prostate cancer and died at age 65, and I'm really, really worried. Or my brother had prostate cancer, and now I'm really worried. He told me I have to get checked. So that's often the way people show up. By the time symptoms show up, blood in the urine, difficulty with urination, sometimes people present with metastasis, with broken bones from prostate cancer. It's really very late-stage disease. And there's been a huge stage migration since the advent of PSA testing and screening. To lower stage disease where it's actually more curable. And this is despite the U.S. Preventive Task Force recommendation against PSA screening.
Right. A couple of years ago, all of a sudden we were shocked that they came out and said, hey, stop drawing the PSAs. And there was, at least in the medical community, a lot of outrage, a lot of disagreement with that. And patients are back now to getting their PSAs checked.
So it's very interesting that the literature looked at, there were a lot of people who studied this to see what happened after the USPTF stopped recommending PSA testing. And it turns out that there was a very slight, very short-lived dip in PSA testing, and then it rebounded back to its original levels. And I suspect a lot of this is due to patient demand. Everybody knows somebody with prostate cancer or somebody who's had prostate cancer, and everybody's worried.
Yeah, I think
and
that's
PSA
true.
testing is happening anyway.
Is that we all know somebody who's had it. It's such a common disorder. And so for the viewers out there, what you're saying and what we know as physicians is that symptoms are rare early on in early staged prostate cancer. So men watching need to know they have to go to their internist, talk to them about prostate cancer screening, get this blood test, which is a simple stick, 1 vial, prostate specific antigen, a PSA. If the PSA comes back high, or somebody is having symptoms that are very concerning of prostate cancer and they come to you, what are the next steps? What do you normally do for a patient who comes in with a high prostate level on their blood test?
So the algorithm has changed now. In the old days, you had a finger test, you might have gotten a PSA or a blood test, and you went straight to a biopsy. Today, multiparametric prostate MRI, specifically designed to image the prostate, has been very useful in diagnosing prostate cancer and staging and in follow-up of prostate cancer. Now, this is not a black box technology. This is not like CAT scan where it kind of doesn't matter what the generation of machine you have, and it kind of doesn't matter what the protocol of the study is or who's looking at it. It pretty much gives you the same result. MRI has to be optimized for the situation that you're trying to identify. So for prostate MRI, it requires a certain magnet strength. We're no longer using endorectal coils, so everybody should be very happy about that.
So
but it does
nothing
require
is placed in the rectum anymore.
nothing inside. It's only body surface coils.
You've given our viewers 2 pieces of good news so far.
I'm
I'm
glad
sure
I
they're
could
very
help.
happy to hear not so much the finger test and no longer a coil is
And
needed.
no coil in the
placed
rectum.
inside during the exam. So the MRI, the patient just sits there or lays there.
Well, they lay there. The machine is a bit noisy and it's a little disconcerting to some people. And the study takes probably about 35 to 40 minutes to do. It's done with an injection of contrast, and it has to be run by a technologist who understands the study and read by a radiologist with experience. So we have spent about 4 years optimizing this, and our director of prostate imaging, Dr. Shaiknevsky, does an excellent job in performing these and in reading them as well.
So patients, once they're suspected, undergo this special type of an MRI, which is, again, non-invasive. There's no pain involved in an MRI aside from having an IV placed for the contrast. So after the MRI comes back, if you see something suspicious, where do we go from there?
Or even if you don't see something suspicious, that's good information as well. Depending upon the MRI result and the PSA result, your next step is a biopsy. And this, unfortunately, is the part that you can't get out of, because you don't have cancer until the pathologist looks at it on the slide and says, that's the cancer right there. The MRI informs the biopsy strategy. Years ago, we used to do straight transrectal biopsies, which meant that the probe was put in the rectum, the biopsy was done through the rectum, and that was pretty good at diagnosing most of the tumors which were on the back surface of the prostate accessible through the rectum. But there are a proportion of tumors that are not on the back part of the prostate that formerly were never identified. The MRI is very good at showing those, and now the biopsies are done, instead of through the rectum, they're done through the skin between the testicles and the rectum. The area is called the perineum. There's a small triangle there, which is very, very close to the prostate. And surprisingly, patients complain less about this. It's actually less painful to do it that way than to survive a biopsy through the rectum. And the route is very good at biopsying areas of the prostate that were formerly inaccessible. The technology has changed dramatically. Years ago, we used to use just the ultrasound to try to localize these, and today it's possible to fuse any abnormal areas of the MRI to the ultrasound in real time, so that the physician is looking at the ultrasound picture with a picture of the MRI superimposed on top of it, directing you to the exact lesion that may have been seen on the MRI for biopsy. So the diagnostic accuracy has gone up tremendously.